Hi, I'm Dr. Bone.
I'm Joanne Koechner.
And my guest today for our channel is an occupational therapist. And her name is Joanne Koechner, and she works in mid-Missouri. Would you tell me a little bit about your background, your education? How did you get into occupational therapy?
Well, a very interesting event happened. I happened to run across occupational therapy. I was a dental assistant and loved working with my patients, but felt there was always something I was supposed to do in my life. Felt that I didn't know what I wanted to do when I grew up. And at the age of 27, I ran across occupational therapy and felt a chill run down my spine and knew God was calling me to do this job. So I investigated, and the University of Missouri accepted me as a 27-year-old student. And I graduated in 1995.
So you've done occupational therapy for a while then.
Yes.
You got a lot of rich experience, I'm sure.
Absolutely, in many different parts of occupational therapy.
And that's what we want to tap in today, is we want to tap into that history and that information about what occupational therapy really is, and what is that when somebody says, oh, I need an OT consult. What does that mean?
It generally means that we need to look at the holistic approach of a patient, that we need to look and see how they're functioning in their home, in their environment. It's not only their physical ability, but their cognitive abilities, and if they're safe in their environment and able to be as independent and safe in their ADLs and their activities of daily life.
Can you tell me a little bit what makes your healthcare subdivision, what makes OT different than PT? How is occupational therapy different than physical therapy?
Well, with occupational therapy, we kind of feel like we're kind of shoved to the side because everybody looks at physical therapy. Everybody, every single one of my patients, the first thing I ask them is, what do you want? What is your goal? And they all want to walk. Of course, everybody wants to walk, especially if you're not able to walk or get around by yourself. But with occupational therapy, we take that to a different level. Physical therapy looks at the muscle groups. They look at strength, balance, being able to physically walk across the room. And with occupational therapy, we take that to a different level because we are looking at someone being independent, someone being able to cook a meal, someone being able to dance, someone able to put on the clothes, all these factors that go into place that we have to help someone get to that independent level. And it's not just walking.
So it's more than just strength and balance and being able to walk 200 feet.
Exactly.
It's more about how you use those muscles to do everyday things.
Absolutely. And also we pull in that cognitive aspect, how they're thinking. And with that cognition, we also pull in the vision. Can they see their environment? What can we do to modify it in order for them to be as independent as possible and safe? We want to prevent falls. We want them to be as independent in their environment so that they can stay in that environment. So there's all these factors that we will look at, including maybe some changes in the environment that we need to make. It's not unusual for us to come in and do a home assessment and say, it would be better if you take off this door to the bathroom because you can't get a wheelchair or a walker through safely.
Wow.
So, yeah, we do a lot of environmental. We look at and see where they might need some grab bars, or we go into the shower and we say, this isn't going to be safe for them. Let's look at another option. Sometimes the shower and tub are just not a good, safe option, and we look at a way in which they can do a sink bath for a while until modifications can be made.
That is very different than physical therapy, because it seems like when I've talked with physical therapists, they're more about patients' strength and their ability to perform tasks, but it sounds like you're doing home assessments.
Yes, we do a lot, and sometimes it's a matter of, can the person get out of bed? Because we think of safety. We think, can they get out of bed if there is an urgent need to get out the door, such as a fire or something going on. So if they can't get out of bed, we look at, is a railing that we can suggest that you can put on the bed, or even that, sometimes it's about looking at acquiring a hospital bed, something that they can raise and lower themselves in order to safely get out. And on top of that, just the whole environment, making sure that they have a nice path to make it to the door to safety. So,
wow. So, how the patient functions in their own home is really a big part of what you do on a daily basis.
yes, on a daily basis.
I know that there's a big push right now for aging in place.
Absolutely. That's our focus. We want people to stay in their homes. In fact, hospitals are discharging to home where they used to discharge to a rehab facility, or sometimes in the skilled unit of a nursing home. They would send patients who had had hip fractures, knee replacements, shoulder replacements, or major surgeries. But now the hospitals are sending them home. So home health has been a big focus, in which we actually do all that therapy that was once in those skilled facilities, we are now doing in the homes. So that's the big push. So we want to make sure people are safe when they get there. That's our priority, and that they can independently get around safely.
When you see a patient, tell me some of the environments. Do you see them in a hospital? Do you see them in a nursing home? Do you see them in an AL? Do you see them in an IL? Do you see them at their home? Mm-hmm. Tell me an environment that you would see somebody at. And that's nursing home, assisted living, independent living, or hospital setting. What kind of setting do you see these people?
Well, occupational therapy is involved in all the settings. In the hospital, we're just focused on the immediate need. So the immediate need is mainly to go to the bathroom, get out of bed, go to the bathroom. Focusing on that for the patient, making sure they can wash their face, brush their teeth, that type of thing. And then when they get to the skilled nursing, that's usually it used to be the major part of the next step. So they would go either to skilled nursing or to home health. We would go a little further with it. We would do some training and some adaptations, especially if they've had a hip fracture and are under restrictions. They can't bend forward, can't weight bear, they may be using a wheelchair. We do those immediate trainings. We train on how to use adaptive equipment to get dressed, and just even standing tolerance and reaching while you're standing using one hand. So that's part of the balance, because nobody can do an ADL without at least one hand. I mean, it's almost impossible. And then as we go into assisted living, independent living, those are another area that is really large. It's a large growing population. If people can't be at home, they're choosing, or maybe they don't want to do the whole home environment anymore. It's too much for them. They'll go into an assisted living or an independent living. With the independent living is they just stepped out of their home. They no longer are needing to have that big of a home, but they want someone else to do the major care. They may want the social aspect. So for some of these people, they may just have some weakness. They've had a few falls, and we want to make sure that we can come in there, assess the environment, because it is their home, it is their apartment, and make sure that they're independent and safe to remain living in that environment, because they also do their own cooking and cleaning in that environment. So what we do is we focus on those major, we call them more high level in ADLs, we call them IADLs. And then
those are the instrumental activities of daily living.
Instrumental activities of daily living.
So the activities of daily living are the things to get up, comb your hair, brush your teeth.
Those are your basic.
Go to the bathroom.
Yep.
And the instrumental are like using your telephone, using your toaster.
Right. Cooking a little meal, going to the grocery store, making a grocery plan, doing your finances, keeping track of your doctor's appointments, and all of those are real. Leisure activities are a big thing. If we find someone who's not attending their leisure activities, not going to outings like they used to, we look at that and say, what's going on? What can we do to help? And it may be a cognitive factor, it may be a weakness, there's something going on.
Something's preventing them from being fully independent. So a person who lives in their own home is the most independent.
Right.
And then if they relinquish some of that and they decide, I don't want all the responsibility of being a homeowner or a home renter, they might go to the next level, which would be independent living. So some of those things would be cared for by the facility where they lived at.
And they like that social aspect, a lot of them do. There's other people around, just it's kind of an older community that in that way, and they don't have to rely upon their family for so much for the outside things, like for the yard work. And usually those facilities will offer transport, so they don't have to have someone take them to the doctor.
So they might have a shuttle.
Yes. So that's really nice. Now, when they become where they can't cook their meals or handle their own medication, usually the medication is the big factor there, where they need a nurse to overlook their care, that's when they move to the assisted living. That's the big, usually the medication, the falls, or something's going on that they just can't do it anymore independently, then they move to the assisted side. And that's where we start coming in to try to make them and ensure that they're safe to get in and out of a shower, be able to bathe themselves safely. Because there's different levels of care in the assisted living.
Wow.
And at different levels of care, it comes a different price level. Because all of these are usually individually paid out.
So you have like your apartment, like an independent living, but with the assisted living, you're telling me that the facility would provide certain amount of support.
Yes, they provide usually the meals, the laundry, the medication management.
Those sort of like a college kid living in a dorm.
Yeah, absolutely. You're just there,
and
you get to live, but you have that support.
You got a place that you can go that somebody's going to cook for you. Now, would they also provide some assistance, like for your room care, making your bed?
Yes. Now, they usually provide that on a daily, every other day basis. So in between that time with the assisted living, they're still responsible for some light homemaking, but not usually any meals. Most of them do come with like a little kitchenette, in which you might have a microwave, you usually have a refrigerator, something that you can make yourself a little meal if you choose not to eat what they're having in the communal dining. But they also have nursing to check on them about every shift, which is 8 to 10 hours, to ensure the person is safe. I really like ours. Not only is it in the assisted living, but the independent living aspect. They have what they call the flush schedule, or flush report, the flush report. And the flush report is when was the last time the toilet was flushed. So that can be a real big safety, because when we know that when the toilet has been flushed, someone hasn't gotten up, or someone may be on the floor.
So how does that get reported?
There's an electronic thing on the toilet.
Wow.
And it monitors it, so it'll notify when the last flush happened.
Wow.
So when I've worked in the assisted living, independent living, I was shocked because I didn't know that existed, and they were like, we got to go check on Mr. So-and-so. The flush report says the toilet has been flushed since 8 o'clock last night. So here it is, 9 o'clock in the morning.
Because they have a lot of privacy in assisted living facility, where they live in their own apartment, but the staff will check on them or maybe deliver meds to them. But the patient can choose to go to breakfast or not. And if the patient chooses to go out with family, the facility might know that they've left the building.
Right.
But if the patient's in the building and it's not time for their medications, that flush report might alert the staff.
Absolutely, that there's something going on. And that's happened quite a few times. I was really shocked. I didn't know something like that existed until working in that
So when
environment.
I worked in assisted living facility environment, we used a lot of occupational therapy if the staff would tell us that a resident, that somebody who lived there, was now having more difficulty performing certain tasks that they had been able to accomplish because of the aging in place.
Absolutely.
Focus, trying to get people to stay where they are and not need a higher level of care. We used a lot of occupational therapy to do evaluations of what that patient's abilities
Right, right. So we do so many evaluations. There's different aspects. So we may focus on just general, whereas the ADLs, where are they at? Where are they doing? And then there are some very specialized ones we do. We do a urinary incontinence because we know that some people, as we age, start to have urinary incontinence, and with that comes the high risk for falls, also for urinary tract infections, sending people back to the hospital, put them at risk for their health. So we will work on strengthening those muscles. We go through a program with them to help them understand how to care for that. So that's a really big one. We also have a low vision, which we look at what we need to do in order to help someone be able to operate the stove or the microwave, or just get around operating the hot and cold, to be able to get around in their environment. There's different things that we put in place to help them.
Now, I've written OT for low vision, but I would like for you to talk about another one that I've written for, is OT for energy conservation.
Oh, yes.
Now, that sounds, what do you mean energy conservation? Are you going to use solar, or are we going to turn the lights out? So I want you to talk to me a little bit about energy conservation, what that means, and who is that population that would benefit from energy conservation?
Well, we have quite a few people that would benefit from the energy conservation, but the ones that I see the biggest, who need it the most, the greatest need, is the ones who have conditions such as COPD, or anything with the breathing, whether it's COPD
or a heart condition,
lung condition.
Somebody that wears out easily.
And it could be even if they have cancer. We've had some for those that have cancer because they get fatigued so quickly. So what we do is we work on educating them and training them in different ways in which we might use adaptive equipment to show them how to get dressed again versus you doing it and expending your energy. We do task segmentation, so we're training them this little task first, then let's proceed to here. Instead of doing everything, trying to do everything at once, we break it down for them. Because otherwise they may by the time they get their pants on and their shirt on a day, they're done. So they're never going to put on their shoes or their socks, and then they're just going to lay around all day. So we do things to help simplify that. And then they may not eat. So we do task simplification for cooking, what you can do to make things a little easier so you're not expending all your energy, and how to do it from a sitting position and what to bring in to do that with, and instead of from a standing. Also the adaptive equipment that you need with a walker. People think, oh yeah, we can just make a meal and use our walker and walk back. That doesn't always happen. By the time you stand for a few minutes cooking, if they're standing or rinsing dishes or whatever they're doing, they're worn out. So we look at that and we say, maybe there's a different way we can help that environment in order for them to be able to get this task completed so that they can get back to daily living.
So it's not just reachers and sock butlers.
Mm-hmm. No.
And a reacher is like what you see at like one of the like Walmart or something, where it's a grabber on the end of a stick and they can pick something up. Mm-hmm. And then the sock butler is so that they, when they go to put their socks on, they can
don't have to bend over.
They don't have to bend over. But it's about making them be able to have more energy by doing things in blocks.
In blocks, yes. And also that deep breathing technique. We use different methods for that, really concentrating on their breathing so that they're not holding their breath trying to get something done. We all do that. Hold our breath trying to get it done fast. That they learn to breathe through that so that they can last longer.
So we talked a little about in-home care and independent care, and then you might need to go to the next level, which would be assisted living care. And when assisted living is no longer good enough or no longer supportive enough, the person now needs a higher level of care, either because of a medical problem or because of frailty. Mm-hmm. Then we end up going to like nursing level care, right. And there's skilled nursing, and then there's
just long-term care.
Long-term care, okay.
Right. And with skilled nursing, usually skilled nursing happens an initial admit into the facility after you've had a condition that qualifies you for it. So if you've been in the hospital and you now can't go home and assisted living is not a possibility, and you go into a skilled nursing facility, we work on trying to increase your abilities through using a lot of the adaptive equipment if necessary in order to be the best you can be to possibly qualify for the assisted living, maybe independent living, or returning home. And with that, we really are focused on strength, endurance, standing activity tolerance, safety, cognition. A lot of times speech therapy comes in during that time and will help us with the cognitive aspect, but focusing greatly on the physical at that point in order to return to a higher level of living.
So tell me a little bit more about the difference between long-term nursing care and skilled care, right?
Right. So with skilled care, we were looking at getting someone better in order to return to their previous environment. That was the main focus, or return to their previous level. With long-term care, we're focused, now that's their environment. So their environment is this is
the highest level of function.
That's
Okay.
their highest level. We've realized that person is not ever going to be safe to return home to that environment without 24-hour help. So when we look at someone in long-term care, we're looking at factors such as what assistance they need to get in and out of bed, what assistance they need in order to do the basic things such as feeding themselves, brushing their teeth, washing their face, how much assistance they need to get onto a toilet, off a toilet. Those things we try to keep and focus on keeping them at the highest level they can be in that level of care, which is sometimes it may be educating the staff on how to transfer them to the toilet and how to let them do as much as they can for themselves.
So the responsibility is not all on the person.
Right.
Some of the responsibility is educating the staff that's caring for that person.
Most definitely. That's where a bigger part of our long-term care therapy goes. So.
What's the difference between skilled care and rehab? Is there a difference there, or is that the same thing?
It depends on where you're looking at. Rehab sometimes is outpatient rehab, so we may be focused on hand therapy in the rehab aspect. Or if they're having dysfunction, they have neck issues, a lot of times we work on strengthening of the cervical muscles, relieving some pain. Occupational therapy really focuses on upper body. Physical therapy focuses on the lower part of the body, so they focus on the legs, we focus on the arms.
Okay.
And so in rehab, especially in outpatient, you'll find an occupational therapist who's really working on the shoulders, the hands, maybe an elbow joint, something.
So if a person goes to the hospital and they have like a joint replacement, and they're there for a few days and they have a need for rehab, they used to be able to go to rehab for like 90 to 100 days. That was the old Medicare thing. Do they still do that?
No. It's still written that way, but it's usually
It's changed so much
Yes.
over the last
Yes.
few years. That,
2020 it started changing. Yes.
Okay.
So in 2020 they had implemented some new changes in the pay system, and
that's Medicare, right?
It is Medicare, and so
Whatever Medicare does, everybody else follows.
everybody follows. So what I see is that about 2 weeks, about 20 days, people are in skilled or rehab, and then they are out.
And then they go to a different level of care.
Yes, they transition. So
But years ago, as a physician, if I had a patient who was hospitalized for 3 midnights, they didn't go by the number of hours you were in the hospital. So if you got admitted at 8 a.m., then you had to still stay 3 midnights. If you were admitted at 10 p.m. and you were admitted, and that was a billing term, if you were admitted, then those 3 midnights entitled a person to be able to stay in the hospital entitled the person after the hospital stay to 90 to 100 days of rehab. And
Right.
you don't get that anymore.
no, we used to be able to rehab someone, especially after like a hip fracture, and someone can't even stand by themselves. Now imagine them going home, what they're going to need to be able to do. And we used to be able to do that. And the average, I think at that time, was around 45 days to 60 days in our skilled nursing or rehab. And now they get about 20 days.
Yeah, I know that when I talk to patients about rehab, and I see, as a palliative physician, I see a lot of frail people. I talk with them about rehab for the patient and tell the families rehab for your loved one is sort of like boot camp, where they are going to pack in so many hours of therapy. It could be physical therapy, it could be occupational therapy, it might be speech therapy, but they're going to pack in so much therapy into a few hours for 5 or 6 days a week,
Right.
that it's like boot camp. I just compare it to boot camp for older people.
Yeah, we would have an hour of occupational therapy, an hour of physical therapy, and sometimes there's a need for 45 minutes to an hour of speech therapy. It depended on what the effects were. If someone had a stroke, it was 3 hours. There was no doubt. And sometimes we even added an afternoon session. So
It could be 4 or 5 hours in a day.
Yes.
And is it just 5 days a week and they get weekends off?
It used to be, well, we had switched it to 7 days a week.
So it's every day.
So it was every day. And now because of the pay system and Medicare, it has switched down. So it's now usually 5. Some places still offer 6, but
Wow.
it has changed tremendously. They usually are individual. We may be in the gym with other people getting treatment, but on top of that, we do offer some group settings. Because with these people, sometimes they need to see someone else doing and participating, so if they get motivated, that they're going to make a change too. Some come out of this with a little bit of down mood. I don't want to say depression, but just it's really hard for them. They've never been to a point in their life where they had to depend upon somebody else to do the basic things. So sometimes a little group setting helps them, brings them up a little bit. It gives them hope, brings them to the level they need to be and start really making some good progress.
Because they're maybe at one point in their rehabilitation with the therapist, and then they see somebody who's a little further ahead of them, and they see somebody who is just beginning. And I can see how that, seeing others also on that same path might provide a little bit of encouragement that, hey, they're doing this, they've had a hardship.
Absolutely.
I can do this too. And it would give a little bit of a competitive atmosphere maybe. And I think the generation and population that we care for is a little bit, I can do this.
I can do this. You did it, I'm going to do it.
I'm going to do it too. We're in this together. I can see how that.
So we do individual, we do some group, but the focus is always to get the person the best that they can be.
I really want to thank you for your time today. I appreciate you kind of going through a little bit about what occupational therapy is and how it differs from physical therapy. And then I've learned a lot about the different levels of care, that occupational therapy can see somebody in their own home and do a home assessment. And occupational therapy can see somebody in an independent living or assisted living environment and what they could do for them there. And then there's some of the different disease processes and order types that would be needed for energy conservation or low vision. Those are, very
Absolutely.
Interesting. And then the rehab, nursing home, skilled nursing home, those nuances and how that has changed over just the most recent short period of time.
Absolutely. It's been so fast. But we have adjusted, and so have the patients. I am amazed. So,
if you had a tip or something to offer a patient is about occupational therapy, how to obtain occupational therapy, would you have a tip or a suggestion?
well, part of what I think, and this is just my own personal thought, is as we age, we all should be looking at our environment and saying to ourselves, is this going to be an environment that is going to be doable if I have to be in a wheelchair, if I have to have a walker, if I have to have someone come stay with me, because sometimes children move home to care for their parents. Is everything at a level in my kitchen to where it's accessible if I can't reach it right now? maybe I need to get rid of it or move it. Those types of things will, as you prepare for your aging, I think are a big factor. Handrails in the bathroom. I can't go over that enough. A raised toilet, a higher toilet. Those things we don't think about as we're this age.
Yeah.
But
yeah.
in another 10, 20 years, it may be a big factor. Or I may fall and wish I had a walk-in shower versus a tub shower if I have a hip replaced. Those types of things, or knee done. So looking at those things, and then occupational therapy is great to help look at your environment and look at you and making sure that you can stay safely in there, training you and to be as independent as you can and safe as you can in your own home.
Okay. And what about a myth? Do you feel like there are some myths about occupational therapy that you'd like to bust?
Well, the biggest one is when I say to someone, I'm an occupational therapist, I'm here to do an evaluation, they will say, oh, I don't need a job.
Okay. That I wondered about that, because a lot of people, when they hear occupational therapy, they think, oh, this is because, I'm a mechanic and I need occupational therapy.
Right.
So it's not about work as employed.
Right.
It's work in your own home.
Exactly.
It's being able to be functional, go to the bathroom, use your sink, use your toaster oven, use your washing machine.
Absolutely.
Get your dirty clothes from the laundry basket into the
laundry room.
and then get them folded and get them back to your. Okay.
All these little tasks that we just take for granted that are every day. That's what we look at.
Well, I really appreciate you joining us today and learning more about occupational therapy, and I appreciate your time. Thanks so much.
You're welcome. Thank you.
Joanne Koechner, Dr. Bone, thank you for your time.
Have a great day.